Everyone. Thanks for joining us for another Health for the World Radiology webinar. Today we are honored to have Dr. Jinsuh Kim join us to talk about brain MRI of Alzheimer's disease and new treatments. Dr. Kim completed his neuroradiology fellowship at Johns Hopkins Hospital and a second neuroradiology fellowship at Hartford Hospital. He's currently an associate professor of radiology at Emory University. Please feel free, everyone, to write your questions in the Q&A box at the bottom of the screen, and we'll get to them in the last 15 minutes of the lecture. Dr. Kim, thank you so much for joining us today, and we look forward to hearing your lecture.
Thank you for inviting me. It was a great pleasure to speak at this large group of the audience, and I feel kind of honored. My name is Jinsuh Kim. I'm attending neuroradiologist at Emory University Hospital. Today's talk will cover mostly some Alzheimer's disease and MRI brain MRI evaluation briefly, and more importantly, cover some recent anti-amyloid drug-related imaging abnormalities. I hope this talk can help to understand neuroimaging roles and new diagnostic framework of the Alzheimer's disease, and hope you can understand emerging new immunotherapeutic drugs for Alzheimer's disease, and ARIA, which stands for amyloid-related imaging abnormalities. Brain MRI plays an important role, as you know, for accurate recognition of major dementia types, such as Alzheimer's disease, frontotemporal dementia, Lewy body dementia, and vascular dementia. And rule out other etiologies like stroke and NPH and brain tumor. Other cause of the dementia is also important. Alzheimer's disease is the most well-known type of the dementia and account for approximately 60% of all dementias. And other vascular dementia, Lewy body dementia, frontotemporal dementia, and other remainders account for about 40% of cases. Alzheimer's disease is a truly devastating neurodegenerative disease affecting at least 55 million people worldwide, which progressively compromise cognition and function and behavior. Continuum development of the symptom from prodromal MCI to dementia takes about 15 to 25 years. The pathologic hallmark of Alzheimer's disease are neuritic plaque composed of the amyloid beta peptide and neurofibrillary tangle of the hyperphosphorylated tau protein. The recent research confirmed presence of amyloid beta abnormality up to 25 years prior to first symptomatic onset. Traditionally, Alzheimer's disease has been clinical pathologic entity. That means establishment of Alzheimer's disease diagnosis require clinical evidence and pathology of amyloid beta deposit. Recent NIA Alzheimer's Associated Research Framework recommend the use of CSF and imaging biomarkers in Alzheimer's disease diagnosis. In this framework, aggregated amyloid beta is placed at the apex of the diagnostic hierarchy, followed by aggregated tau and neurodegeneration evidenced by anatomic MRI, FDG PET, and CSF total tau. As you notice, there is a parenthesis around N, which implies it does not map onto neuropathologic findings such as amyloid beta and phosphorylated tau. Typically, brain atrophy in Alzheimer's disease occur predominantly in medial temporal lobe areas, and classical Alzheimer's A4E4 allele positive, presenting at older ages and usually associated with memory deficit. There is an atypical variant Alzheimer's disease, which predominant brain atrophy seen in the posterior cortical region and frontal lobe area. Posterior cortical atrophy is also called visual variant AD or Vanson syndrome, and which is characteristically ApoE negative and presenile onset. This figure shows 6 PCA patient groups, voxel-based morphometry and FDG PET, the group comparison. So use the 12 normal control data and demonstrating the parieto-occipital and posterior temporal predominant brain atrophy and more wide pronounced hypometabolism on FDG PET. Frontal variant manifest often the behavioral symptoms which need to be differentiated with frontotemporal dementia or Lewy body dementia. Neuropathologically, there are also hippocampal sparing and limbic predominant variant present. In brain MRI workup of dementia, qualitative visual rating scales are commonly used, which include a physical score for white matter hyperintensity, reflecting small vessel ischemic disease, and microbleed anatomical rating scale, MARS, Pascal scale for global cortical atrophy, and Quedam scale for posterior cortical atrophy, and Shelton scale for medial temporal lobe atrophy. Here is the physical score from 1 to 3, and global cortical atrophy score from 0 to this is the 3, but and also this is the Quedam scale of the parieto-occipital atrophy scale. In early stage AD, brain volume loss is often subtle and heterogeneously distributed, and visual assessment is often focused to the temporal brain regions. Medial temporal lobe atrophy score is rated from 0 to 4 on single coronary imaging. At the level of the cerebral peduncle and mammillary body is the most representative coronal cut. MTA0 is normal for all age. MTA 1 is minimal atrophy, normal for younger than age 75. 2 is mild atrophy, normal for older than 75. 3, 4 are moderate and severe respectively, and that are well correlated with the dementia, relatively well correlated. In grade 0, those self-visible around the hippocampus. In grade 1, you see the cortical fissure slightly widened. Grade 2 shows moderate widening of the cortical fissure, mild enlargement of the temporal horn, and mild loss of hippocampal height. Grade 3 shows marked enlargement, widening of corridor fissure, moderate temporal horn enlargement, and moderate hippocampal atrophy. Grade 4 shows severely atrophic hippocampi with loss of internal structure. The rationale of the ARIA, entorhinal cortical atrophy score, is based on Brock neurofibrillary tangle staging, which initiated from the transentorhinal region, and then it spread out and propagate gradually to the limbic and neocortex area. And so we are focusing on the entorhinal cortex and parahippocampal gyrus. It is known that the capturing pattern of the entorhinal cortical atrophy provide better diagnostic accuracy in distinguishing AD from normal aging. ARIA 0 is here, indicate normal volume of the entorhinal cortex and parahippocampal gyrus, as you see here. Score 1 indicate mild atrophy with wide collateral circles is indicated here. As score 2, moderate atrophy of entorhinal cortex is detached from the cerebellar tentorium, which is called tentorial cleft sign, as seen in this white arrow. At score 3, pronounced atrophy of the parahippocampal gyrus with a wide tentorial cleft is evident. So quantitative neuroimaging is known to be more sensitive to detect neurodegeneration of preclinical and mild AD compared to the visual qualitative imaging assessment. Now, FDA approved commercial software NeuroQuant has been available quite a while. That provides more quantitative values evaluation. The raw volume of the hippocampi and ventricle and intracranial percentage volumes and age-specific normal range are provided. So key biomarkers and potential biological targets serve a very important role in early diagnosis and drug development of Alzheimer's disease. Previous major therapeutic target of Alzheimer's disease have been acetylcholinesterase and NMDA receptor, the antagonist, and this paradigm has been shifted to the targeting amyloid and tau pathologies as the current consensus. Therefore, there is a anti-amyloid monoclonal antibody drugs become new kids on the block. Amyloid hypothesis is still dominant paradigm of Alzheimer pathogenesis. This schema shows the pathophysiology of the Alzheimer disease. So in normal physiology, produced amyloid precursor protein undergoes enzymatic cleavage into soluble amyloid beta peptide within the cell with a gamma and beta secretase cleave the peptide, and then extracellular space there is the peptide degradation normally by the white blood cell, so amyloid beta the degradation, or it can undergo the clearance by glymphatic system during the sleep, and some cholesterol metabolism involved, and hepatorenal secretion is also part of role for the amyloid beta clearance. But in Alzheimer's disease, APP, presenilin 1 and 2 gene mutated often, and that induce the overproduction of the amyloid beta, create the clump of the neuritic plaque, as a senile plaque in here, and then hypophosphorylation of tau. So there is a neurofibrillary tangle of the extracellular space. And then that induce microglial activation, resulting in toxic effect to the neuron. Because of a huge demand of new Alzheimer treatment options, and the limited option for currently, FDA granted unprecedented accelerated approval of aducanumab in 2020, solely based on dose-dependent reduction of amyloid beta deposition on PET, despite the primary endpoint of 2 phase 3 clinical trials were not met. An advisory panel of the FDA vote was against the approval. And similar accelerated approval pathway for lecanemab, Leqembi, was initially approved in January 2023 after successful phase 3 clinical trial. And later, it was converted to traditional full approval in July. Accelerated approval for donanemab was rejected initially due to not enough safety data, but it is expected to be approved by end of this year. So based on amyloid hypothesis, aim of the anti-amyloid beta monoclonal antibody drug is to reduce amyloid deposit burden by preventing toxic clumping of beta amyloid protein. Primary targets of these drugs are a little different. For example, lecanemab binds to soluble protofibril, and aducanumab binds to insoluble amyloid beta 2 oligomer fibrils, and donanemab binds to the nucleated plaque. During clinical trial of bapineuzumab, which is the earliest, one of the earliest monoclonal antibody drug, investigators identify spectrum of abnormal MRI finding in treated patient, and subsequently Alzheimer Associated Research Work Group coined terminology of ARIA, amyloid-related imaging abnormality. There are two designations of ARIA. ARIA E with E stands for edema, representing proteinaceous fluid, and ARIA H with H stands for hemorrhage, representing blood degradation product. And also there is a the classification depending on location. ARIA E is further divided by the parenchymal location, parenchymal type, and the leptomeningeal type, which present as a sulcal effusion and exudate. And ARIA H is divided as a cerebral microbleed and superficial cirrhosis. ARIA pathophysiology is not really fully understood yet, but the working hypothesis is in this diagram. In healthy brain, soluble amyloid beta predominantly clear through the perivascular transportation. So the produced amyloid beta is not accumulated. And in Alzheimer's disease, amyloid plaques are accumulated in the parenchyma and blood vessel wall, smooth muscles layer by the impaired perivascular clearance. And early immunization of the monoclonal antibody, anti-amyloid drug mobilize the beta amyloid from the parenchyma and vessel wall, smooth muscle, and then that results in the facilitate amyloid trafficking through the perivascular space. And this mobilization of the amyloid plaques, the peptide resulting in the weakening of the vessel wall and blood-brain barrier are disrupted, subsequently leading to vasogenic edema and also sometimes erythrocyte leaking, causing microbleed. And this is the early immunization stage. And later stage, once the amyloid plaques are removed and the cell wall integrity is reconstituted, and then the further vasogenic edema leaking is prevented in repeated immunization. Severity grade in radiology report can be useful for stratifying patient risk for further brain damage. ARIA E and ARIA H are commonly graded with a 3-point scale as mild, moderate, and severe. ARIA E severity grading is based on the extent 5 centimeter, 5 to 10 centimeter, and over 10 centimeter, and as well as the focality, the multiplicity count. And whereas the ARIA H is graded by number of hemorrhagic lesions. Frankly, I do not have experience of good ARIA case. These images are taken from the literature to demonstrate the different severity grade. On the left column, 3 different severity case of parenchymal E ARIA is demonstrated. Post-dosing MRI scan shows focal vasogenic edema less than 5 centimeter, designate mild degree. Multifocal vasogenic edema with less than 5 centimeter in extent is rated as moderate because of the multifocal disease. Severe ARIA E case shows a very extensive vasogenic edema with sulcal effacement involving the right hollow hemispheric brain. Next column is sulcal type ARIA E. Mild case shows treatment emergent sulcal flare hyperintensity smaller than 5 centimeter. Moderate ARIA E case with sulcal flare hyperintensity between 5 to 10 centimeter in extent. A case of the small bilateral occipital flare hyperintensity lesion is also graded as a moderate case because of the multifocality. And diffuse bilateral occipital and temporal sulcal effusion designated as a severe ARIA E. Single focus of microhemorrhage on post-dosing scan is mild ARIA H microbleed, and moderate case with 5 to 10 microbleed, and severe case with more than 10 microbleed. And here is the superficial siderosis type of ARIA H. Treatment emergent superficial siderosis as single focus is mild ARIA H. assessed, although this case is accompanied with multifocal small microhemorrhage posteriorly. It's still the single focus of superficial sclerosis, so the ARIA HSS grade is still mild. And bifrontal superficial sclerosis, 2 foci is moderate, and 3 or more cases will be the severe. So overall incidence of ARIA E was 35% among the treatment group of the aducanumab. Incidence among ApoE4 carrier group was 2 times higher than non-carrier group. ARIA E occurred most of ARIA E occurred less than 1 year after treatment or within 4 to 8 doses. The majority of cases were asymptomatic and resolved within 20 weeks. Although ARIA H was less common, only 19% of the microhemorrhage and 15% of superficial sclerosis. This hemorrhage is just remain permanently on follow-up images. Aducanumab trial identifies several risk factors. Incidence of ARIA tends to be increased with ApoE4 carriership, increased drug dosage, an early period of the immunization, and severe underlying cerebral amyloid angiopathy in old age of the patient. ARIA E and ARIA H are often temporally and spatially associated. ARIA H coexists about 50% case of ARIA E, and ARIA H is often harbinger of subtle ARIA E. The example images here, post-dosing MRI shows mild ARIA E and concurrent mild ARIA H. And 1 month follow-up MRI shows progressed ARIA E to moderate degree, as well as ARIA H progression to moderate degree as well. In 2 months, however, ARIA E was completely resolved, but number of the microhemorrhages are increased. So it's the rate of our study was discrepant. So there are 4 well-known anti-amyloid monoclonal antibody drugs on the market. And all of these drugs are effective to clear CNS amyloid burden. Lecanemab and donanemab are modestly effective in slowing cognitive impairment of the early Alzheimer's disease patient. Clinical effectiveness of the aducanumab was inconsistent with 2 phase 3 clinical trial. Tau reduction effect of the donanemab is not known. And ARIA E incidence was as high as 42% in aducanumab and as low as 10% in lecanemab. Interestingly, ARIA H incidence of aducanumab was not high compared to other drugs, but and then the incidence was pretty close to the placebo. This chart shows a typical dosing and MRI monitoring schedule. Baseline MRI should be done within 1 year prior to dose initiation. and monthly dose is given with dose escalation every 2 months until reaching target dose. Routine MRI schedule is before 5, 7, and 12 dosage. And screening MRI surveillance is very important for this drug trial because of ARIA. So when ARIA is suspected, MRI evaluation is recommended any time. Clinical trial recommend MRI protocol with the most basic sequence, including the 2D flare image and 2D GRE T2 star weighted image, and just the DWI. So mostly just a non-con exam, but if there is some question and some region characterization is requested, additional imaging sequence, including the contrast enhanced MRI is advised. Quantitative scoring, rating scale, and severity index in the radiology report will be very useful for clinical guidance. So baseline MRI is also important to screen patient with underlying brain hemorrhage, infarction, cerebral amyloid angiopathy, and several the cerebral microvascular ischemic disease. So if you see the one greater than 1 centimeter macrohemorrhage, acute infarction, and severe case of CAA, patients should not be included in the clinical trial. If MRI surveillance identify ARIA, that will be a dilemma to continue treatment or temporary or permanent dose suspension. So decision tree is seen here. Asymptomatic and mild ARIA-E or ARIA-H case, patient can have continued treatment with monthly MRI follow-up. And symptomatic or moderate or severe ARIA case need to dose suspension with monthly MRI evaluation until resolution of edema and stabilization of hemorrhage. And also notice that those stopping criteria include any anticoagulation circumstances. There are a few diseases that overlap the pathophysiology and MRI findings of ARIA. In press, increased intravascular pressure, failed vasogenic, failed vasomotor autoregulation, causing endothelial damage and blood-brain barrier disruption. It occurs often in the context of hypertensive emergency, but the press can be found at multiple other etiologies, such as preeclampsia, eclampsia, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, autoimmune disease, and also immune suppression drug like tacrolimus, cyclosporin. And most of the press is associated with acute neurological symptom. This case shows patches of cortical hyperdensity on flare, predominantly involving the parietal and occipital area. Acute infarction is easily diagnosed with diffusion weight MRI, as seen this diffusion restriction, so it's quite straightforward. However, normalized diffusion abnormality in subacute infarction can be similar to parenchyma ARIA E. Subarachnoid hemorrhage is another disease to differentiate it from the ARIA E circle type. Blood product in subarachnoid space shows flare hyperintensity. Also, the leptomeningeal CSF non-suppression flare can be seen in meningitis, leptomeningeal carcinomatosis, supplementary oxygen therapy, and propofol IV or artifact from the metal implant. In this case, the subarachnoid blood is the Brydon T1, which is giveaway is a subarachnoid hemorrhage. Cerebral amyloid angiopathy is microvascular degenerative disease characterized by amyloid beta deposition in cortical and leptomeningeal blood vessels, usually affecting posterior brain area like parietal and occipital regions. Sporadic CAA and Alzheimer's disease significantly overlapped, and there was a report that CAA found about 90% in Alzheimer's disease at autopsy. Boston criteria is clinical and MRI-based diagnostic guideline useful to distinguish CAA from TIA, and also useful to stratify ICH risk. Multiple cerebral microbleeds are very common in chronic hypertensive patients. Hypertensive microangiopathy frequently involves the deep gray and brainstem areas, and sometimes macrohemorrhage and superficial siderosis can be associated, as seen in this case. This patient had AFib and cardiogenic embolic shower to the brain, and MRI demonstrate the disseminated susceptibility foci on SWI throughout the almost entire anterior circulation territory, but sparing the posterior fossa area. CAA-related inflammation, CAA-RI, is a rare autoimmune encephalopathy associated with the anti-amyloid antibody. So this autoimmune antibody and inflammation is just like ARIA E. In fact, ARIA E is the iatrogenic version of CAA-RI. And this CAA-RI case shows microbleed, and the pathologically there is an immune cell infiltration around the CAA positive vessel wall. So CAA-RI is often treated with immunosuppression because it is autoimmune disease. ABRA, amyloid beta-related anxieties, share a common feature of the vascular amyloid disease. But the difference of this ABRA is it involves the frank vasculitic destruction of vessel wall, in contrast to perivascular inflammation in CAA-RI. This ABRA case demonstrates right temporal occipital vasogenic edema, focal microbleed, no diffusion restriction, and increased amyloid uptake, amyloid beta uptake in matched brain area. This is the 55-year-old female patient presenting with acute mental status change. This case also shows the temporal occipital predominant vasogenic edema, but absent the microhemorrhage on GRE, and biopsy confirmed as ARIA. So this is summary. As emerging anti-amyloid drug become valuable therapeutic option, radiologists need to be aware of ARIA, which is the most significant complication of new treatment. Risk factor of ARIA include ApoE for allele carriership and drug dose and then underlying CAA and old age. Incidence of ARIA decrease with the increased duration of exposure. And incidence of ARIA reoccurrence after resolution is pretty low. And appropriate use of anti-amyloid drugs recommend uninterrupted dose through in asymptomatic mild ARIA and dose suspension for symptomatic and moderate or severe ARIA. I think this is my last slide, and thank you for your attention.
Thank you, Dr. Kim, for the comprehensive lecture. A lot of information in there with lots to learn. We do have a question. So the question is the staging on imaging correlated with clinical symptoms?
You mean the ARIA and imaging?
It's not clarified. The question is whether we see a correlation between the staging that we see on imaging versus the clinical presentation of the patient.
The clinical correlation is probably not my expertise. So as far as I understand, the imaging finding and clinical correlation is not really great. But I can not precisely answer that question. I'm sorry.
Okay. We don't have any more questions. There was the only question that we had. The second question is the repetition of the first one. But we'll wait a minute to see if a question comes up. But we are getting comments in the chat box that says that lecture was excellent. Dr. Monero, he's a regular attendee of our lectures. He says excellent lecture.
Oh, thank you very much.
I don't believe we'll be getting another question. So I believe that concludes our run rounds for this week. Thank you, Dr. Kim, for taking the time out of your schedule to volunteer for this course and for this comprehensive lecture. Really appreciate it.
Thank you very much.